Hello everyone. So welcome to this discussion of pharmacology, one of the most important topics in your examination. As you know, at least 20 questions are expected, and here in this session I'm going to cover obviously the most important topics that you must revise in this last mile. So as you all know, like yesterday in the live session we had some issues and we could not upload that video directly on the YouTube. So again, I'm recording this video for all of you from the beginning, and I'm going to discuss everything from the start. So in this, I'm not going to give you a lot of time after the questions in case obviously you're watching it later. So you may pause the question, read it, and you may take your answers, and later on you may check what we are discussing. All right. So without any further ado, let's start with our question number 1. So doctors, as you can see in this case, there's a 22-year-old previously healthy male who was brought to the ER by his friends after he began to act strange at a hostel party. They reported that the patient was confused, agitated, and started talking to the imaginary people. He then removed his clothes, complaining of feeling hot. His friends admitted that he has ingested some unknown substance to enhance spiritual experience. Which of the following must be the cause of this presentation? Okay, so the key points that we need to pay attention to, that the patient was confused, right? He was talking to imaginary people, that means hallucinations. Now, maybe the person has ingested some kind of a hallucinogen, all right? So imaginary friends, I'm taking one word as a hint. Second, he removed his clothes feeling hot. Okay, this is another thing. Hypothermia, maybe he's feeling too hot, that's why he removed his clothes. As you can see, the patient has ingested something. Now let's look into the options. The question is asking what could have caused this issue. Now there are 4 options: paracetamol, OPs, Datura, and opioid. Now let's ask ourselves a question. In a party, do you think people would consume paracetamol to commit a suicide or something? Obviously no. So this cannot be that paracetamol poisoning. Nor it could be OPs, because OPs are pesticides. That means logically, if I rule out, I am left out with 2 options. One is Datura and the second is opioids, right? So Datura and opioid, that's what the answer lies in. And here we go. Opioids work on mu receptor, as we all know, and Datura, it is a guy that will reduce parasympathetic activity. So parasympathetic activity, if you reduce, obviously you will start feeling hot, etc., because acetylcholine is a part of it. So when acetylcholine is blocked, the secretions are blocked, and when secretions are blocked, what ends up happening, you will feel hot. Sweating is not happening, so you can't cool down your body, and now you're going to feel hot. So here's where the correct answer is going to be Datura. Okay, so Datura toxicity seems to be the most appropriate answer that we can go for in this. All right, so now if you remember from our sessions, we used to learn that there are 3 guys who will cause a similar type of a situation: belladonna, atropine, and Datura. The mnemonic BAD. So belladonna, atropine, and Datura. These are the 3 guys that will cause reduction in the parasympathetic. All right. And the antidote to treat them is physostigmine. Now in this, we are going to have a quick discussion of the important toxicology aspects that they may ask in your exam. One is OP poisoning. Second is Datura, cocaine, and opioid. As I told you, Datura decreases parasympathetic activity. Okay, it decreases parasympathetic activity. So that is written in the mechanism. That's what it is doing. It's reducing the parasympathetic action. And what ends up happening if you reduce parasympathetic, we will see here. Okay. On contrary, OP poisoning, it will increase parasympathetic. And how does it do that? By blocking one enzyme called acetylcholine esterase. As we all know, this enzyme degrades acetylcholine. It breaks down acetylcholine. So if you block this enzyme, acetylcholine does not break down, and what ends up happening is you will get more parasympathetic activity. And this we usually learn by the mnemonic, that is dumbbells, right? So dumbbells is the mnemonic that is going to happen. That is diarrhea, increase in the GI motility, urination increases, meiosis, bronchoconstriction, bradycardia, emesis, lacrimation, salivation. These are all the features of parasympathetic. And if you have decrease in parasympathetic, we can say opposite of dumbbells will happen. All right, here's where you will get stimulation of dumbbells, and here's where you'll get opposite of dumbbells, right? Because this is reducing parasympathetic. Instead of diarrhea, you may get constipation. Instead of more urination, you will get urinary retention, mydriasis, tachycardia, everything opposite. Here it is brady, here it is tachy. Okay, so hope all of you got this idea. So guys, in OP poisoning, as there is too much parasympathetic activity, the aim of the treatment is to reduce it. And to reduce that, I am going to give you a drug that is known as atropine. Okay, atropine. How does atropine work? It blocks muscarinic receptor. It blocks muscarinic receptor. That's the mechanism of action of atropine. All right. So now that we said this, we must also remember that in the OP poisoning, O for OP, O for oximes, there are some more drugs that we can add called as oximes, that are enzyme reactivators. Okay. Next is Datura. Datura, as I said, is reducing parasympathetic. Opposite of dumbbells will happen. There are others also who can do the same, that is belladonna and atropine also. We just said atropine reduces parasympathetic activity. This is where we learned it. So these three guys, that is the mnemonic BAD which I usually teach in the class, these three guys, they reduce parasympathetic, and now I want to increase it. And how do I increase parasympathetic back again? By a drug called physostigmine. Physostigmine. And this drug works by blocking the enzyme acetylcholinesterase. As we already learned, parasympathetic activity will increase due to that. Okay. Now cocaine. Cocaine tends to increase the sympathetic action. So sympathetic features will increase, like heart rate increases, mydriasis, etc., etc. Okay. Now, more or less, there is a symptomatic treatment for cocaine toxicity. There is not such special antidote. Opioids, if you talk about, opioids work by stimulating a receptor called mu receptor, which causes certain features, obviously. So one of the things that you must keep in mind is, if somebody has ingested opioids, there is a classical triad the patient is going to present with. So what is that triad by which the patient comes to us? Now, dear friends, one is pinpoint pupil. As you know that this meiosis can be called as pinpoint pupil, right? Too much meiosis is simply known as pinpoint pupil. Okay. Respiratory depression and unconsciousness. So I'm just telling you the opioid triad, that is pinpoint pupil, respiratory depression, and the unconsciousness. That's how the patient will come. But if you check the heart rate, etc., they will be like bradycardic, etc., etc. Okay. Now, since we have discussed all of this, what is the antidote that we are going to give for the opioid poisoning? It is a drug called naloxone. All right. So initiation of the treatment is done by naloxone. Later on, once the patient is more stable, we can give the oral drug, which is a longer acting drug, and that longer acting drug is called naltrexone. So short acting drug initially given, but it's IV. It's useful in emergency. It is naloxone, and this would be followed by naltrexone. All right. So that's about the poisonings here. Next is question number 2. A child ingested one of the medicines that was prescribed to his parent in the treatment of myasthenia gravis. Examination shows the child has mydriasis, flushed face, hypothermia, constipation, and tachycardia. What should be administered in the treatment of this child? Okay. Now, based on what we discussed just now, at least you should be able to quickly pick up. That means mydriasis, hypothermia, constipation, tachycardia. These all features seem to be more or less like reduction in the parasympathetic activity. All right. So in this, what has happened? The patient is having decrease in the parasympathetic features. All right. Now, patient was, patient has ingested some drug which was given for myasthenia gravis. Okay, let's now discuss something. If we talk about this guy, that is myasthenia gravis, the problem in this disease that we must understand, it is that the muscles are relaxed in the patient. Muscles become excessively relaxed in this patient. That is the problem that is faced by myasthenia patient. So what do you think we should do as a doctor? Contract the muscle. Contract the muscle. So how am I going to contract the muscle? We all know a guy called acetylcholine can contract the muscle, because acetylcholine can work on a receptor called muscarinic receptor, and it works on a receptor called nicotinic receptor. Now, by working on the nicotinic receptor, it causes the skeletal muscle contraction, which I want in the treatment of myasthenia. All right, I want this to happen. But then there is also increase in parasympathetic functions that we can expect when you are increasing acetylcholine. So if you increase acetylcholine, two things will happen. I want only one thing, that is muscle contraction, but what is coming as a side effect? Increase in parasympathetic functions. So what do we do in this treatment is that we must block this muscarinic receptor by giving a drug called atropine. Atropine is not the treatment of myasthenia. Why is atropine given here is, when we treat myasthenia by some drugs. What are these drugs that are given here? The drugs called stigmines, right? The drugs called stigmine. So when you give stigmine drugs, what is happening? Acetylcholine level increases, and when acetylcholine level increases, what ends up happening? You will get muscle contraction, what you wanted in the myasthenia treatment, but side effects will come. Now, to reduce the side effects, we are going to give atropine. All right. So that's why the treatment will be stigmine drug plus atropine. Okay. So now the question was asking, what do you think was given to the patient here? What do you think the patient was given, and then the child has ingested that and got symptoms? Okay. Since we saw the symptoms are reduction in the parasympathetic, the child must have ingested atropine. If the question asked what did the child ingest, answer would have been atropine. But the question asked, how do you treat this child? Right? How do you treat this child? What is the antidote of atropine toxicity we just learned a while ago? The answer is physostigmine. All right, physostigmine. Remember I said it here. Belladonna, Datura or atropine toxicity, it is treated by an antidote called physostigmine. Okay. Now, let's have a quick run through this topic of myasthenia gravis, something that we must learn here. So, doctors, when the patient comes to us, usually the patient will be having ptosis. Ptosis is drooping eyelid, which is due to muscles of the eye getting relaxed, right? So, the eyelid muscles are relaxed in this patient, so the patient comes with ptosis. Okay, so what are we going to do in the testing? Okay. In the testing, I'm going to give this person one drug, and that drug goes by the name of edrophonium. Now, the reason usually we prefer edrophonium is because it's a short-acting drug, and since it is short-acting, I can prefer it in the diagnostics, right? So, this is a test, what we call as tensilon test. So, as we said, the patient comes to us with relaxed eyelid, that is ptosis. So what do we do now is we are going to give them a drug called edrophonium, and edrophonium will start contracting the muscles. And once their muscles contract, what happens? The eyelid will be opening now, right? Until now it was shut, but now it's going to open up, As you can see, the patient feels better. So when the eyelid opens, it's a sign that the patient is feeling better. When you give a drug that contracts muscles, that means the patient must be having a disease called myasthenia. Once you have confirmed it by more tests, obviously this is one of the tests. There are more tests that we are going to do. What we do finally is we are going to give the treatment, that is a drug called pyridostigmine, which is going to be better compared to neostigmine. So both can be used, both are stigmines, but as you know, they can cause side effect, increase in parasympathetic. And how do you reduce that side effect? We're going to add a drug that is called atropine. Atropine is simply given to reduce the side effects of stigmine drugs. Okay, so that's all about it. This is myasthenia gravis. And now here we have the next question. Based on the charts or the graph that is given to us, we need to recognize what is drug A, B, and C. So how do you approach this question? As you can see, in one place, the heart rate, that is pulse rate, is given, and in the second, the blood pressure is given. Now you need to understand some values are there, but you don't need to pay that much attention. You can just see how the lines are going. Now, they're saying that when a drug A is given, what is happening to the blood pressure? You can see this is the baseline of the blood pressure. So what is happening is the blood pressure is increasing, right? Here itself, you could have seen the arrow. The blood pressure is increasing. This is what has happened just now. The blood pressure increased when you gave this drug. And what happened to the heart rate? You can see the heart rate was supposed to be like this, but the heart rate went down. Yes or no? This line is going down. That means the heart rate went down. That means they're saying that if you give this drug, the BP will increase, but the heart rate will decrease. Now look at the drug B. Drug B, what has it done is, once again, it has increased the blood pressure. If you can see baseline, the blood pressure is going up and the heart rate also went up. Okay, the heart rate also went up. So this is a drug that increases both BP also, heart rate also. Next, drug C. It is increasing the heart rate, as once again it is seen here. Heart rate is increasing and the BP is not increasing. More or less we can say it is decreasing. Okay, so it remains the same or it may decrease. All right, so let us just say that who is this drug who can do this? So you need to know this pattern, memorize this. Obviously, I can't discuss every concept in this rapid revision right here. I will just ask you to memorize this important fact, because definitely there can be a potential question on this. They may simply give it in wordings like which is the drug that could increase blood pressure, decrease something, and something like that. Or they may give you a graphical format like this. So either ways, you should be able to recognize what they're asking you. All right. So let's memorize. What is the drug that will increase BP, but it will reduce heart rate? The answer is noradrenaline. Now you can see noradrenaline is present in B also, D also. Two options has that. Okay. So answer could be B or D. Next, what is drug B? Increasing heart rate, increasing BP. The answer is adrenaline. Because second option is adrenaline, from this given options, the answer is this. So what does NORAD do? NORAD will increase BP, reduce heart rate. What will the adrenaline do? Increase BP, increase heart rate. And what will the drug C called isoprenaline do? Isoprenaline will increase heart rate, but it will reduce, BP. So that's it. That is the correct answer in this. Next question provokes a thought. It's a question that requires a thinking. If a patient is given adrenaline injection for the treatment of anaphylactic shock, and the drug X is also given, following which the patient develops profuse hypertension, which of the following could be the drug X? Okay, so what are they saying? First, they gave adrenaline and they gave some drug, that is drug X. After giving the new drug apart from adrenaline, the BP went down. Have you figured out what concept are we discussing here? Guys, this is the all famous thing what we call as vasomotor reversal of Dale. Along with adrenaline, if you give a alpha blocker, the BP decreases, right? So what is the alpha blocker from this list that can be given? That is given. It is phentolamine. Probably phentolamine was given to the patient and this ended up happening. All right. So now let's try to understand this concept. So this goes back to the receptors where these drugs function on. Okay. Now first, let's try and figure out what does adrenaline do, then what does noradrenaline do. Okay. So if we talk about noradrenaline drug, what happens to the blood pressure? In this previous graphs that we discussed, I said that noradrenaline as well as adrenaline both increase BP. But in the graph also you can see the BP is increased much more when compared to adrenaline. Noradrenaline increases BP much more. Drug A is NORAD, right? NORAD is increasing the BP much more. The height is more compared to adrenaline. So why is that? Let's try to understand this here. Noradrenaline, it stimulates only alpha-1 receptor in the body. As we know, alpha-1 receptor causes vasoconstriction. That means since it's causing only vasoconstriction, the BP will not only increase, it will increase quite well. Okay, let's compare it to somebody called adrenaline this time. Now, if we give adrenaline to somebody, let's see what happens to the BP. Okay. Adrenaline, as you must know, it works on alpha-1, which causes vasoconstriction, and it also works on beta-2, which causes vasodilation, right? Alpha-1 causes vasoconstriction, which will increase BP. Beta-2 causes vasodilation, which will reduce BP. Now, you will say, sir, if it is like that, then the BP should stay neutral now. Why is it increasing? Here we go. The word alpha. Alpha means the dominant, guys. We use the word like alpha male, right? Today in this generation, you call it sigma male, but the word is alpha male. So alphas are dominant. They will be dominating. That means there is more vasoconstriction compared to vasodilation. Overall, the winner will be alphas. Hence, the BP increases. But it's not increasing so much because there is opposition. Somebody is reducing the BP also. Are you understanding that? So that is what is happening here. Both will increase BP, but one will increase BP much more. And who is that guy? Noradrenaline. That's why in the picture, noradrenaline, once again, I'm repeating, it increases BP much more. Adrenaline also increases, but not as much. Okay. So now that we figured this out, what is the experiment of vasomotor reversal of Dale? Now, what did that guy do in the vasomotor reversal of Dale? Okay, vasomotor reversal of Dale. This guy has given alpha blocker additionally, apart from giving noradrenaline and adrenaline to the patients. Okay, he added alpha blockers. He added alpha blockers to these drugs. Let's see what will happen. Okay, if you gave these drugs alone, you know the BP increased by both the drugs, right? Whether you gave this, whether you gave that, BP had increased by both these drugs. Okay, now let's add alpha blocker and see what will happen. Here we go, friends. Let's say if I gave noradrenaline to the patient, I gave noradrenaline to the patient, plus I added a alpha blocker. As the name says, alpha blocker will block the alpha receptor. Alpha blocker will block the alpha receptor. So now the BP cannot increase. So BP stays pretty much the same. Now if we give adrenaline to the patient, okay, if we give adrenaline to the patient and we give alpha blocker, now we will give alpha blocker, same story. Ab you tell me what will happen. If I give adrenaline plus alpha blocker, alpha is blocked but beta is still working. Yes or no? Beta is still working. And what is beta doing? Vasodilation, that will reduce BP. So that means when we give adrenaline plus alpha blocker, BP reduced. Adrenaline plus some drug, BP reduced, hypotension. And why did the BP reduce? Because beta is working. And this was the experiment he did to prove that adrenaline works on which receptor? Beta 2 receptor. Okay, so that's why the correct answer here is phentolamine. Some of you will argue, sir, tamsulosin is also an alpha blocker. It's not a direct, it's not just a alpha blocker, it's a very selective alpha blocker. It's a alpha 1A. It works mainly on prostate. It doesn't work on blood vessels. That's why, although it's an alpha blocker, it cannot be the answer. Okay. Quick run through in this session, that is adrenaline. You must know it's used for anaphylactic shock, dear friends. And what is the route that is preferred for anaphylactic shock? It is intramuscular, and this is given on the thigh. The concentration to be given here, it is 1:1000. 1:1000. Okay, so this is the route that we will prefer. Next, what does this 1 means here? This 1 means 1 gram adrenaline. Okay, so this 1, wherever it is written, whether here, it means 1 gram adrenaline. And what does this 1000 and 10,000 means? This 1000 or 10,000 means it is the amount of liquid it is present in. 1 is 1000 ml or 1:10,000 ml. All right. Cardiac arrest, the better route is IV. For the heart, IV route is better. But for anaphylactic shock, IM route is better. Okay. So now that we said that, I already explained to you the vasomotor reversal of Dale. Let's quickly revise. Giving adrenaline plus alpha blocker to the patient will cause reduction in the BP. Why is the BP decreasing? Because the alphas are blocked, betas are still working. So the beta 2 receptor causes vasodilation. That is why this happened. Unopposed beta 2, that will cause this effect. Okay. Next question, a 32-year-old male presents with complaints of excessive thirst and urination for the past 3 weeks. He reports waking up multiple times at night to void large amounts of clear urine. Physical exam is unremarkable. His serum osmolality is increased and urine osmolality is decreased. Which of the following is the drug of choice? Okay, so the patient is having polyuria. This is confirmed from the history. The patient wakes up multiple times at night to urinate. Osmolality is given. Serum osmolality is increased and urine osmolality is decreased. Okay, so why is this happening? See, you all know our fluids have some solutes in them. Our fluids have some solutes in them, right? Solutes means some salt. Imagine like that. So now I'm asking you one question. If you are urinating too much, what happens in the urine is there is too much water. If you're losing too much water in the urine, this area becomes dilute. Do you agree? Too much water, if you're losing in the urine, then the urine becomes dilute. That means the osmolality is decreasing here. Dilution means osmolality is decreasing. Okay. Is this true? Next, if you see what is happening in the body, because I'm losing the water from the body, what is happening in the plasma? I'm losing the water. That means now the solutes will increase. That means osmolarity increases in the plasma. So simply put, if you are seeing your body is getting more saturated, if your body is getting more saturated and if your urine is getting dilute, this is a sign that you're having a loss of water from the body, and this is the disease in which this happened. Diabetes insipidus. See, you must remember both the diabetes, whether it is mellitus or insipidus causes polyuria, right? You're going to lose water. So what is the problem in diabetes insipidus? The patient does not have, there are two types primarily, one is nephrogenic and one is central or neurogenic. Let me just give you the neurogenic one. Neurogenic means you don't have, there is absence of ADH, which is also called as vasopressin. Okay, ADH or vasopressin. ADH is what? Antidiuretic. Antidiuretic means it doesn't allow diuresis. Antidiuretic means it will save water. If the ADH is present, you can save water, but if you don't have ADH, you will lose water. That's what is happening in diabetes insipidus. Since they don't have ADH, they're losing water. And that's why I'm going to give you a drug that can save water. Since you don't have vasopressin, I will give you vasopressin from outside by a drug called as desmopressin. Desmopressin. All right. Now, if you see bethanacol, what will desmopressin do? It will save water for you. It will help you decrease the urination. It will help you decrease the urination. Okay. Bethanacol neostigmine, these are drugs that will increase parasympathetic. They will actually increase urination. They can't be given here, sir. Tolvaptan, the name says vasopressin antagonist, AN for antagonist. That means it will decrease ADH, sir. It will decrease ADH or vasopressin. That is Vaptan drugs. Sir, you tell me, already ADH is less in the patient. Do you think you should reduce it more? Of course, no. So where are Vaptans used? Vaptans are used when you are having too much of ADH. There is a disease known as SIADH. In the SIADH, there is too much ADH. So that's where we should reduce it. That's where we give Vaptans. Okay. Next, this is the picture where you are having the consolidation of the topic called diuretics. Because this is a topic that is routinely tested in your exam, at least one MCQ comes, sometime 2 to 3 also will show up from diuretics topic alone. So I want you to make sure you revise this from here, right? So now, if you check this out here, on the Doctor's Day, yesterday was the Doctor's Day, consider this as my gift to all of you. So obviously, I hope you guys understand it takes efforts. We have to type these things, make charts like this so that you guys find it easier and you guys get on your pathways to success. Okay. So only thing we want is a smile on your face tomorrow when you get a question. And if this helps you solve, hopefully you'll remember me. And once you pass your exam, I'll get a text from you. That's I did it. That will make me the happiest person. Despite we may not know each other, right? There are many of you who attend this session who are not even my students. But yet, if you happen to text me that you did well, it makes us happy. I guess that's the relationship of a faculty and a student. And we just gain our energy session after sessions to go just by, seeing your results, the happiness that you guys get and your parents. Okay. So anyway, looking into this, what is one type of a question? Simply they can ask you which diuretic is used where, right? Pulmonary edema, cerebral edema, blah, blah, blah. So that is all there. So you have to revise this. But I believe the exam is evolving. So they may end up asking you questions which are, slightly on a upper level. So I know for a fact that everybody knows the drug of choice for mountain sickness. If I ask, you will say, sir, it is acetazolamide. So let's upgrade our game, right? We want to know something more or beyond the mountain sickness. So here's where there is a mnemonic game. As a child, we used to play games with car. Yes or no? With cars, we used to play games. So please, I would like all of you to remember this. If you're talking about the mnemonic game, right? This is the uses of the drugs called carbonic anhydrase inhibitors, drugs like acetazolamide, dorzolamide, etc. Okay. Now that we saw this, please remember whenever you block carbonic anhydrase, you can expect stones as one side effect. Okay, just keep that in mind. Next thing, these drugs have sulfa group in them, so they can cause sulfa allergies. This also you must keep in mind. Carbonic anhydrase inhibitors, they cause sulfa allergies. Next, loop diuretics are drugs like furosemide, that is your Lasix. Okay, which channel is blocked by them? Sodium potassium chloride, drug of choice in pulmonary edema. So go through this chart, later on. The drugs that work in collecting duct are potassium sparing diuretics. Potassium sparing diuretics. Now, you must keep in mind when we talk about potassium sparing drugs, please remember, if the potassium is staying in the body, we are saying to potassium, please stay, please have a seat. When you want somebody to stay, we say, please have a seat. Okay. So spironolactone, eplerenone, amiloride, triamterene, these are the examples. From this, aldosterone blocker is spironolactone. It is the drug of choice for these three conditions. Spironolactone, it is the drug of choice for cons, cirrhotic edema, and resistant hypertension. And amiloride, it is the drug of choice for excessive ENaC situations like Liddle syndrome, lithium-induced diabetes, insipidus. Okay, so that's all about this. Let's keep an eye on this topic. Next, here we go to this question. A 67-year-old man with a history of chronic hypertension and a history of myocardial infarction presented with shortness of breath, fatigue, edema in feet, and irregular heartbeats. Echo shows EF of 34% and BNP levels were also elevated. Which of the following would not decrease the mortality in this patient? Make it a habit that you're reading the question always properly. For example, sometimes we may end up missing this kind of words and that will cost us that 1 mark. Silly mistakes, except not this kind of words you should read well. So what are we seeing in this question? A hypertensive case, had a MI before. What do you think the patient will develop eventually? Heart failure, yes or no? How did I get to know or confirm that this patient has heart failure? Two things were mentioned. One, the ejection fraction is less. You can see it's 34. Ejection fraction is very less. And second, BNP levels, pro-BNP levels are elevated in the heart failure patients. So both the tests were given. So I know that this is a case of heart failure. Okay. So when we talk about a disease called congestive heart failure, we must all know there are two varieties of this heart failure. Acute, which is more severe, and chronic, which is relatively less severe. So what happens in this diseases is ejection fraction is decreased in both the disease, but it is decreased much more in the acute heart failure, as acute diseases simply means more serious. Okay, we all know acute disease is more serious disease, yes or no? So I am simply saying that ejection fraction is very, very less. What do you want to do in this patient? If you increase the force of contraction of the heart, obviously the ejection fraction will increase. Ejecting percentage of the blood will increase. So I need to increase the force of contraction. What do you call the force of contraction? Inotropy, yes or no? So what is the aim of the treatment here? In the acute CHF, I want to increase force of contraction called inotropy. And to increase the inotropy, we have a drug called dobutamine, which is there in this list, option B. Next, chronic heart failure, what do I want to do? In the chronic heart failure, the aim of the doctor, it is to reduce the workload in this patient. Reducing the workload will reduce something which will cause, which is known as cardiac remodeling in your internal medicine. You must have heard this word. Reducing the workload reduces cardiac remodeling, and reducing the cardiac remodeling will reduce mortality. I can also say reducing mortality means increasing survival. Increasing survival. So I asked you which drug does not decrease mortality. That means only the drugs which are working in the chronic heart failure, that is reducing cardiac remodeling, only they can reduce mortality. That means a drug which is on this end, it will not reduce mortality, sir. And which is that drug I said which doesn't reduce mortality? Dobutamine. Yes, it's used in heart failure, but its intention is different. Okay, dobutamine, it is used only in the acute heart failure along with furosemide to treat the pulmonary edema. Okay, and this is the place where you're having this other drugs like sacubitril, valsartan, carvedilol. All of those drugs are used in the chronic CHF. Okay, now let's discuss a thing or two about the chronic CHF. Now you must remember the drugs that are reducing the mortality are these drugs. Okay, so it's a cool thing, obviously, to reduce mortality to save lives. So we're going to remember super cool bhai saab, right? This is the mnemonic that you have to remember. Super, sacubitril, cool. There's a drug from diabetes in this topic now called canagliflozin or SGLT2 inhibitors that has been now approved to treat heart failure. Bhai saab, you can read what is written. So that's it. Now, beta blockers, ACE inhibitors, ARBs, they are one of the great drugs in the heart failure topic. They are the top drugs, in fact. But even in the beta blockers, which beta blockers are the best ones? We will remember like this: B, C, and M, right? So these drugs cause big decrease in cardiac mortality. Big decrease in the cardiac mortality, right? Are you understanding that? So what are these drugs that will cause a good decrease in the cardiac mortality? The answer is bisoprolol, carvedilol, metoprolol. Okay, so these are the best drugs to be used in the heart failure topic. Okay, now carvedilol also, you must remember, has something special. It has calcium blockade plus alpha blockade activity also. Okay, so carvedilol has calcium plus alpha blockade activity. Okay. Next thing, a 58-year-old male with a history of poorly controlled hypertension presents to the ER with severe headache, palpitations, anxiety, and a blood pressure of 210/120 mm of mercury. He states that he recently ran out of one of his blood pressure medications and has not taken it for the past 2 days. On examination, he is diaphoretic and anxious. ECG shows sinus tachycardia. Which of the following is the most likely cause of his current presentation? Okay, so the patient missed his dose. Something I could figure here, that his blood pressure medications he has missed. And now the BP is looking over the top. So too much blood pressure after missing the dose of blood pressure medicine. Is it ringing any bell? The diagnosis of this situation is rebound hypertension. Okay, we must all know they're talking about rebound hypertension. Rebound hypertension, as you must be knowing, it is happening by a drug called clonidine. So clonidine, the alpha 2 agonist drug, if you miss certain doses of this drug, your BP will not just increase because you missed the dose, it will go up very, very high. That is called as rebound hypertension. And to reduce this BP, we are going to use a drug called phentolamine, which is an alpha blocker. Phentolamine, it is an alpha blocker. All right, so this is an alpha agonist drug. This is why we oppose it by a alpha blocker called phentolamine. Phentolamine is also used in cheese reaction, right? Another severe hypertension is called cheese reaction, where we use phentolamine. Okay, so that's about this. Next one right here. If we talk about the side effects, important side effects from the cardiovascular system, I've just put them together in one place so that it's more easier to revise this way. So let's have a look here, doctors. Now, first of all, cheese reaction, it's a severe hypertension. This is happening by somebody called tyramine. So tyramine causes cheese reaction. Again, the treatment was phentolamine. Coombs test positivity, it is by a drug called methyl-dopa, which is used in pregnancy-induced hypertension. Although the drug of choice for PIH, it is labetalol. Okay, labetalol is the drug of choice, but we can even use methyl-dopa. Okay, next thing, cyanide toxicity, nitroprusside is the one who causes this. Cyanide nitroprusside. Okay, gum swelling and ankle edema, it is the classical side effect of the drugs called dipines. Gum swelling, although it is also seen by phenytoin drug. Okay, next, dry cough angioedema, I guess we all know it as ACE inhibitors known as PRILs. Okay, xanthopsia means vision problems. Okay, vision related side effects, this is seen with digoxin. Synchronism, it is seen by those drugs coming from a plant called cinchona plant derivatives. Cinchona plant derivatives are drugs having quin in the name. Quin drugs are usually in the malaria topic, right? So one of the drugs which is used in the cardiovascular system, it is quinidin. Okay, quinidin, this is the drug that we need to know. This is the drug that will cause this, which presents with tinnitus, ringing sensation in the ear, that is synchronism with quinidin. SLE is caused by 5 drugs called shipped drugs: sulfonamide, hydralazine, isoniazid, procainamide, and dapsone. I repeat, sulfonamide, hydralazine, isoniazid, procainamide, and dapsone. Okay. Next, corneal deposits and the pulmonary fibrosis. It is by a drug called amiodarone. Okay. So you must remember the mnemonic, better check PFT, LFT, that mnemonic which I teach. So amiodarone. Okay. So it contains iodine in its structure. So it causes the thyroid side effects like hypothyroidism also, corneal deposits, pulmonary fibrosis. Pulmonary fibrosis, it is the most dangerous side effect of amiodarone. Okay, most dangerous side effect. Myopathy and myalgia, it is caused by the drugs known as statins. Statins do that. Next, flushing and pruritus, itching and flushing, that is by niacin. Statins are the best drugs to reduce LDL. Niacin is one of the best drugs to increase the triglycerides, the HDL, and the best drug to reduce the triglycerides, it is fibrates. So statins are best for reducing LDL, niacin is best for increasing the HDL, and lastly, fibrates are best for reducing the triglycerides. Purple toe syndrome, it is a side effect that is seen with a anticoagulant drug called warfarin. Coronary steal phenomenon, because of which we don't use this drug anymore in the ischemic heart diseases like MI. This drug is dipyridamole. This is the drug that is going to cause coronary steal phenomenon. Okay. So these were certain important side effects from the cardiovascular system. A 58-year-old woman presents to the OPD with complaints of severe throbbing headache, which is accompanied by the nausea and sensitivity to light and sound. Before the onset of the above symptoms, the woman sees bright flashes of light, numbness, pins and needle sensation. She is also a patient of MI. Which of the following drugs can be used in the treatment? Okay, so what do you get from this? The things that we could gather from the given information is this patient most likely has migraine. Okay, so because they talked about a headache and they're talking about the aura, the bright flashes of light, that means she comes to know before she gets migraine, that is nothing but aura. All right, she is also a patient of myocardial infarction. This history also is an important bit of information that was given. patient is a case of MI. If you don't pay attention to that, minuscule detail, you will end up marking the wrong answer. See, all of us are trained to think the moment I say migraine, triptans are the best drugs, we would say. But here, triptan cannot be given because she is a patient of ischemic heart disease. You all should know in MI, we don't give triptans. That's why the correct answer here will be lasmiditan. The mnemonic that I had given you is less MI. Lasmiditan. It gives you less MI. Less MI deta hai, right? This is the drug that will do that. Lasmiditan. Sumatriptan or the triptans, which are 5-HT1B or D agonist. These drugs are the drug of choice, but you should avoid them in ischemic heart disease, as I said. Ergots are also used. You should remember any drug containing erg in the name. It is a ergot derivative. Any drug having ERG is the ergot derivatives. And ergot derivatives cause vasoconstriction again. That's why they're also useful in migraine. Guys, they cause that vasoconstriction in the fingers also. So they may end up causing gangrene. So you must remember, triptans causes vasoconstriction in the heart vessels, whereas ergots cause the vasoconstriction in the fingers, causing gangrene. So gangrene means rotting, right? So let's remember the mnemonic: ergots, rots, fingers. The mnemonic will be ergots, rots, fingers. Okay, so that's all about it. Quick run through in the topic of migraine. The best drug to prevent migraine, that means you can use in the maintenance, take that every day, it is propranolol. For prophylaxis, propranolol is used. Treatment, triptans. Treatment, triptans, right? So triptans are obviously the best drugs that we have for the treatment. That means if you're having headache right now, that is migraine is happening right now, you should take triptans, but only if it is severe. But if it's just mild to moderate pain, do not go for the higher drugs. Rather, you can treat yourself by a simpler drug, that is NSAIDs. Okay. In ischemic heart disease, triptans cannot be given, as I said, so we should go for lasmiditan. Okay. So that's the end of the migraine. Next, we go to the anti-glaucoma drugs. Again, a very high-yield topic for your exam, the anti-glaucoma drugs. So we must first remember that when we're talking about glaucoma, what is the aim here? We want to reduce the intraocular pressure by reducing the aqueous humor. And how do most of the drugs work? The mechanism of action of most drugs is they reduce production of aqueous humor. They reduce the synthesis or production of aqueous humor. Majority drugs work like this in glaucoma. What are these drugs that can actually do this? The mnemonic ABCD. These 4 drugs are going to do that. A for the drugs called alpha agonist, precisely alpha 2 agonist, drugs like apraclonidin, brimonidin, these drugs. Okay. Next is B for the beta blockers, timolol, bitoxolol, famous drugs from this list. Okay. C for carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors. Next, D for dipivefrin. Okay, dipivefrin. What does dipivefrin sound like? Epinephrine, right? It is a prodrug of epinephrine, dipivefrin. All right. So these are the 4 drugs that will reduce, the synthesis. It will reduce the synthesis here. Now that we have said this, let us move on. The next thing that we must all pay attention to is aqueous humor drainage. Okay, the aqueous humor drainage. Now, dear doctors, if we talk about the aqueous humor drainage, there are 2 pathways by which we can actually delete this, reduce this aqueous humor. Okay, So how exactly are we going to do that? There are two doors. One is called trabecular meshwork and the second is called uveoscleral outflow. Okay, one is trabecular meshwork and the second one would be known as uveoscleral outflow. So who are the drugs who are going to reduce this trabecular meshwork? I mean, increase the drainage through this trabecular meshwork. Let's write this. One is the drugs called miotics. Miotics will be the drugs, examples like pilocarpine, physostigmine, these drugs. Okay, so meiosis opens up the pathway. So pilocarpine, physostigmine, these drugs can be used. These are one of the drugs in this topic. Okay, next, alpha 2 agonist, apraclonidine, brimonidine, these drugs can also do that. Okay, so this is another type of drugs who can do. So we must pay attention. Alpha 2 agonist has two mechanisms. Are you seeing that? Alpha 2 has two mechanisms. They can reduce production also. They can increase drainage also. They work by dual mechanism. All right. And third, a new drug. It is Rho kinase inhibitor. Rho kinase inhibitor. This is a new drug in this list right now. This drug goes by the name of netarsudil. Netarsudil. This is a new drug again. All right. So this drug, Rho kinase inhibitor, is netarsudil. Usually we know that the drug containing dil in the name, they are used in heart. Example, fasodil, okay, diltiazem, or anything that is having dil generally is for the heart, but this is not the one. Netarsudil is used in the eyes. Anyway, you read somebody's heart through eyes only, right? So please do remember. Now, next one, uveoscleral outflow. Okay, uveoscleral outflow. So gentlemen and ladies, this is where we got the drugs called prostaglandins called PGF2 alpha agonist. The drugs having prost in the name. Okay, latanoprost, bimatoprost, I believe everybody is acquainted with these medicines. So these are those drugs that are increasing the uveoscleral outflow. So this is the mechanism of actions, how the drugs in the glaucoma generally work. Okay. Now, certain side effects or certain contraindications of the drugs we use in the glaucoma that we need to know. Which drugs must be avoided in asthmatics? The answer is beta blockers. Although the drugs in glaucoma are given topically, but you must know that topical route can also be absorbed systemically sometimes, and the drugs may end up causing something. Because this question will be asked by many of the doctors. They'll be like, sir, you're putting eye drops. Why am I getting asthma? Because they may get absorbed systemically also. All right. So beta blockers, they are the ones that should be avoided in asthma. It's a general contraindication. See, beta blockers ke contraindication you should all know. They are avoided in asthma patient. They are avoided in diabetic patients, vasospastic diseases. So whatever the things that I might have told you in the classes, beta blocker contraindications are super important. Okay. Next, there is one beta blocker that I'm going to write which can be considered safe in asthma. Okay, safe in asthma. That beta blocker is bitoxolol. Okay, why bitoxolol is considered to be safer? Because it's a cardioselective beta blocker. I hope you remember that there are two types of beta blocker broadly. Non-selective, they should be definitely avoided in asthma. Cardioselective are relatively better, safer. So that's why they can be used in asthma. Example, bitoxolol. Okay. Next, which glaucoma drug should be avoided in children? The answer is brimonidine. Okay. Brimonidine should be avoided in the children. Why should it be avoided in the children? Let's use the first two words of this drug to remember. Number one, we will say B for बच्चों में avoid करना है. We should avoid it in children, बच्चे. All right. Next, R for it causes respiratory depression. Respiratory depression. All right. That is what is leading to apnea. That's why you should avoid this drug. And in general, a side effect of alpha 2 agonists like, brimonidine, apraclonidine, whatever it is that these drugs will cause sedation. Okay, so this drug is an alpha 2 agonist, so it will also cause sedation. CNS depression is also one side effect of these drugs. Okay, and for that reason only we should avoid this in the children. Okay. Next, which drug should be avoided in the uveitis, macular edema? That means inflammatory conditions. Which drug must be avoided? The answer is prostaglandins, PGF2 alpha agonist. PGF2 alpha agonist. These drugs must be avoided. Who should you avoid in hypertension? Hypertension. Okay. Hypertension may we should avoid a drug that can increase your blood pressure, that is epinephrine. Okay, epinephrine, dipivefrin, whatever it is, right? As I said, these drugs can get absorbed systemically, causing this problems. Who should you avoid in sulfur allergy? Sulfur allergy, you should be avoiding the carbonic anhydrase inhibitors. Example, acetazolamide. Acetazolamide. This should be avoided in sulfur allergy. We already learned this in the diuretic part. Okay. Which one is safe in pregnancy? The safest drug is brimonidine. Okay, brimonidine. See, बच्चों में avoid करना है, moms में use करना है. Brimonidine, Brimom, if you remember, moms you can use, but bachcho mein you should avoid due to respiratory inhibition. So that's it. BRI is bachcho mein respiratory inhibition leading to apnea, etc. Avoid this drug, but in moms you can use it. Okay. Next is some drugs of glaucoma treatment. Paradoxically, they themselves can cause glaucoma. Okay, this reason would be taught to you in ophthalmology. We can't get into everything as of now. So just remember that secondary angle closure glaucoma, it is seen by the drugs that is carbonic anhydrase inhibitors. Okay, acetazolamide, brinzolamide, these drugs can cause this secondary angle closure glaucoma. And here we go, understand something what I'm saying next. Dear friends, there are some drugs from epilepsy chapter who can also do the same because they also block carbonic anhydrase enzyme. Carbonic anhydrase enzyme. So who are these drugs? The drugs like topiramate and zonisamide. Topiramate and zonisamide, these are the drugs who can also block carbonic anhydrase. So they can also cause secondary angle closure glaucoma. Who causes conjunctival pigmentation or darkening of the eye? D for D, dipivefrin. Okay, dipivefrin. So that is for the darkening of the eye. Lid retraction. Okay, the eyelid retraction, that is by alpha 2 agonists. Alpha 2 agonists, brimonidine, apraclonidine. Okay, you can see them. See, they are going to do that. Next is allergic blepharoconjunctivitis. This again is seen by drugs like alpha 2 agonist apraclonidine. Next, you can see them with beta blockers like timolol, etc. Okay, so that's another thing. Nasolacrimal duct obstruction, same timolol can do that. Pigmentation of iris, growth of eyelashes, that is hypertrichosis, etc. This is seen by the PGF2 alpha agonist. Okay, drugs like latanoprost, bimatoprost. So guys, mnemonic usually I teach you is PGF only, right? P for pigmentation of iris, G for growth of eyelashes, and F for increases the flow called uveoscleral outflow. Yes, we learned this already. We learned the uveoscleral outflow, correct? Now, look at this picture. Now, in this picture, you can see hyperpigmentations that are being shown. Pigmentation of iris, heterochromia iris, it's seen by the PGF2 alpha agonist, that is drugs like latanoprost, bimatoprost. Next, cornea verticillata or vortex keratopathy, right? If you see this picture, what is happening? You can see this specific appearance that is looking like that. Okay, you don't see such kind of a thing here. Here it is simply darkening, and this darkening can only be seen in the light color eyes more easily. Yes, so here's where you can appreciate this V-shaped structures, hence the V word called vortex. This is seen by that new drug that I told you called nitarsodil. Okay, nitarsodil, it is a add-on drug. It is not the first line drug directly. We are going to add it to the main drugs, okay, like prost or something. Next, some other drugs can also show this vortex keratopathy. So what are these other drugs who can end up doing the same? Drugs like amiodarone, okay. I told you amiodarone also causes corneal deposits. You can check here. Corneal deposits are also seen with amiodarone. All right. So this is where I had told you. So those are the whirl-like deposits or this, this vortex keratopathy. Next, the quin drugs also can do that. Quin drugs means chloroquine, etc. They can also show this side effect to us. Okay. Next, the final takeaway home messages, like which drugs to be given in which glaucoma. See, as we all must be knowing, the open angle glaucoma is mainly managed by medications. Of course, you do have the other options, but the angle closure glaucoma is mostly by some other interventions rather than the drugs. Okay. So open angle glaucoma, this is where the drug of choice is PGF2 alpha agonist, so many times as we said. But let's upscale our game. As I told you, exam can ask you some other questions apart from the regular routine things that we expect. So PGF2 alpha drugs are the drug of choice for open angle glaucoma. But what if they mention the patient is having uveitis? We said that we can't use these pros drugs in uveitis or inflammatory situation. Then the drug of choice becomes brimonidine. Okay, so if the patient is having uveitis or something, then we should go for brimonidine. Angle closure glaucoma. Okay, to open up the angle, we give a miotic pilocarpine, that is considered the drug of choice, right? Best drug, but we can even use latanoprost type of drugs. Okay, so both can be used, preferably the pilocarpine for opening up the angle. And as you know, the best thing, that is the treatment of choice, it is to do the laser iridotomy. Okay. ACG, that is acute congestive glaucoma. Acute means emergency, something serious. All right. So doctors, you and I know that the regular intraocular pressure is supposed to be less than 21 mm of mercury, right? But in ACG, that is acute congestive glaucoma, the IOP is touching the roof. The pressure might be maybe 60 mm of mercury or above. So in those situations, most of the drugs we use in glaucoma do not work. Okay, at such high pressures, where is 20, where is 60? So you cannot use any random drug there. So here's the point. You must all keep in mind, in that I'm going to give you diuretics, and the diuretics that I can give is IV mannitol, or I can even give you acetazolamide. Acetazolamide is even available in the tablet form also. Okay, so mannitol or acetazolamide. Now, after the pressure subsides, right, after it comes down, Now what you can do is you can give them the drug called pilocarpine after this. So pilocarpine is given later on once again. All right. So that's about the topic called glaucoma. Next, we move on to this. The side effects from the CNS topic. Hepatotoxic drug, and it is teratogenic drug. This is none other than your valproate. Valproate is the most teratogenic drug from the antiepileptics, and lamotrigine and levetiracetam are the least teratogenic drugs. Okay. Stevens-Johnson syndrome. Stevens-Johnson syndrome. This is by one drug called lamotrigine, which I just told you is less teratogenic. V for valproate, very teratogenic. L for lamotrigine and levetiracetam, less teratogenic. Okay. There's a drug that can decrease certain vitamins. For example, it reduces vitamin K, it reduces vitamin D, or it reduces vitamin B9, that is folate. So this is none other than your good old friend called phenytoin. Phenytoin. It also causes gum swelling. I told you this before. Dipines also cause gum swelling. Hirsutism is also caused by this, and purple glove syndrome. Guys, do not confuse purple glove syndrome with purple toe syndrome. Purple toe is, warfarin, and the purple glove syndrome is phenytoin. Okay. Hyponatremia. Hyponatremia, it is seen by a drug called oxcarbamazepine or the carbamazepine drug. Okay, oxcarbamazepine or carbamazepine, although it's more common with oxcarbamazepine. Why? Because these drugs, they increase ADH in the body. Okay, what happens if you increase ADH? You will save more water. If you're saving more fluid, obviously the solutes will dilute. So hyponatremia. Okay. Next is nephrolithiasis. I already told you that if you block an enzyme called carbonic anhydrase, you will get stones. That's why we learned the same side effects even in acetazolamide, dorzolamide. Yes. So topiramate and zonisamide. These are the drugs that block carbonic anhydrase, because of which I told you they can cause secondary angle closure glaucoma and they can cause stones also. Blockade of histamine alpha muscarinic receptors. This can happen by the drugs called TCAs, my friend, tricyclic antidepressants, and it can also be happening by first generation antipsychotics. Precisely low potency drugs. Example, chlorpromazine, thioridazine. Those drugs from psychosis topic, they can do this. Delay in the ejaculation, it could happen by SSRIs, anorgasmia. Priapism, painful erection. It is by a drug called trazodone. Now, just a mnemonic to remember this. You must remember the drug as trazodone, because it gives you erection. And what is erection called in normal English? Boner. Trazodone gives you a boner. Okay. Next is diabetes insipidus, called nephrogenic diabetes insipidus, that causes increased in the urination. It is seen by a drug called lithium. You must all be knowing lithium side effects are memorized by the word lithium itself. Example, IU stands for increased urination. M stands for, it's contraindicated in mothers, M for mothers, because it causes Epstein's anomaly. Also, you should remember the lithium, the therapeutic value, you should maintain that in, okay, the therapeutic index. Next, there's a rash that some people can get called livido reticularis. It is again from the CNS topic. It is by a drug called amantadine, which is originally a antiviral drug. which we use in Parkinson's also. It could be used. Although we have better drugs called benztropine, benzhexol, this also can be used. Okay. Now moving to what we call EPS. EPS stands for extra pyramidal side effects. Okay. EPS simply stands for extra pyramidal side effects. So what is the side effects EPS seen with? Who is going to show this? First of all, I would like to tell you that this is one of the most favorite topic of your examiner. Usually they tend to ask you this, like which drugs are going to cause EPS, how do you treat them, etc., etc. So guys, this is caused by antipsychotic drugs. Antipsychotic drugs, they will cause EPS side effects. Now, who will cause this side effect? From them, the drugs called high potency drugs, the strong drugs, high potency drugs, antipsychotics, they will cause this EPS side effects. Examples of high potency drugs are haloperidol from the first generation or typical antipsychotics, and risperidone from atypical or second generation antipsychotics. Okay. You can see the mnemonic ADAPT now to remember the EPS side effects. It's a definitive question, so make sure you all know this properly. So here's where acute dystonia means muscle contractions happen. Example, torticollis. Oculogyric crisis, where the ocular muscles are pulled so that your eyeball goes up like that. So acute dystonia. All right. Next, the treatment that you should give here for this, it is a drug called benzhexol. Benzhexol. So this is what we need to give. Benzhexol is the treatment. Next, the same treatment, that is benzhexol, is also given in Parkinson's, as we know. So remember the mnemonic, park your benz. In Parkinson's, we use benz drugs called benzhexol drugs. In akathisia, we can go for the drugs called beta blockers. Okay. Tardive dyskinesia, you use drugs like deutetrabenzene or tetrabenzene. Okay. So benazine drugs. Okay. Benazine drugs. So those are drugs that we use, deutetrabenzene, tetrabenzene. Next is NMS, that is neuroleptic malignant syndrome. So guys, you must know malignant means something severe. So what is severe here? It's a very severe hyperthermia that can kill you. It's a severe hyperthermia that can kill you. I'm sure you have heard this word in anesthesia also. It's called malignant hyperthermia. It is caused by certain drugs like halothane or succinylcholine, right? Halothane or succinylcholine can do this. Same thing, antipsychotics can do that. All right. So how do you treat it? Whether it is malignant hyperthermia from anesthesia or whether it is EPS from this topic, right? The treatment is one drug called dantrolene. Okay. We are going to use one medicine called dantrolene, which is going to block something called ryanodine receptors. Ryanodine receptors control calcium, which in turn control contraction. If you don't contract your muscles too much, you're not going to get those hyperthermia, right? You're not going to get that hyperthermia. Fine. So that's about it. From this list of drugs, that is antipsychotics, which are known to cause weight gain, which is the drugs that can have maximum risk of weight gain. One, O for obesity, remember it like that. O for olanzapine. Olanzapine and clozapine. Okay, olanzapine and clozapine, they cause weight gain. And which one is weight neutral? Weight neutral means they don't cause weight gain. One is aripiprazole, and the second one, ziprasidone. Okay. Surprisingly, when we say something, right, array, we say it like that, right? So we learned it, array, weight gain nahi ho raha. There is no weight gain that is happening. We use that word. Okay, aripiprazole and ziprasidone. Next, now that we said that hyperprolactinemia happens when you reduce dopamine. When you reduce dopamine, it increases prolactin. This is the rule, right? When you reduce dopamine, prolactin increases. Dopamine is a prolactin inhibitory factor. All right. So, doctors, how do antipsychotics work? They block dopamine, na? So, antipsychotics can cause hyperprolactinemia. The most important drug to do this is risperidone. Okay, risperidone. Next, a 38-year-old female presents to her primary care physician with complaints of polyuria for the past 4 weeks. The patient is 5 feet 8 inches tall. Her calculated BMI is so and so. Family history of diabetes is present. Sedentary lifestyle, so obviously maybe this person also got diabetes. Obviously the sugar levels are given, which confirms the patient has diabetes. Normally the RBS should be how much? Less than 200, right? Here it's 257. So obviously the patient is having diabetes. So which is the drug of choice for diabetes? We all know the drug of choice for diabetes is metformin. Okay, the drug of choice is metformin. And the question is asking the drug of choice of this disease must be avoided in which situation? Answer is renal failure. Because of the risk of lactic acidosis, we should be avoiding metformin in the renal failure patients. Okay, which drug is avoided in IBS? The drugs from this list called alpha glucosidase inhibitors, acarbose like drugs. They should be avoided in irritable bowel because these drugs interfere with absorption of carbohydrates. They lead to flatulence, diarrhea as side effects, and that's the reason you should avoid them in irritable bowel, because they already have those problems. Okay. Another question from diabetes again. 58-year-old male with a 10-year history of type 2 diabetes mellitus presents for a routine checkup. Already on metformin drug, 1000 mg twice a day. HbA1c is still high, 8.7. It's supposed to be less than 6.5 if you're not diabetic. You know, something above 6.5 nearby value is okay, but it's too high, 8.7. All right. GFR is also quite less, 50. It's supposed to be more than 90, but it is, 50. So that means kidney function is also not good. So obviously with this, the patient will have heart problems, kidney problems, etc. So we need to add one drug apart from metformin, which will give the patient cardiorenal protection. Kidney and heart protection will be given by this drug. These are the magical drugs right now in the diabetes topic called gliflozins. Okay, I hope you guys remember the mnemonic I teach you generally. Glucose flows in urine when you give these drugs, and this is happening by the drugs called SGLT2 inhibitors, where the S stands for sodium, so sodium will be lost. G for glucose, glucose will be lost. So glucose and sodium will flow in the urine. If you lose sodium, it's good for the heart patient, yes or no? So that's what is being said here. It's good for the heart patient here, right? So cardiorenal protection would be happening. We learned in the mnemonic super cool bhai saab. Remember, super cool, canagliflozin. That is your SGLT2 inhibitors. All right. Next, another question. A 27-year-old male presents with SOB. Cardiac evaluation is underway, but the chest X-ray reveals left ventricular hypertrophy. Physical exam shows macronathia and prognathia. Oral glucose tolerance test is positive. What is the mechanism of action of the drug that is used in this condition? So I believe by now you must have figured that this is a case of acromegaly. Yes, the diagnosis would be acromegaly. So if you're talking about acromegaly, we need to reduce the growth hormone and this can be reduced by giving the drug that works on somatostatin. Somatostatin analogs, the drugs that will contain the name called rheotides. Okay, the drugs having rheotide in the name, octreotide, lanreotide, they become the drug of choice for the treatment of acromegaly. Okay, any secretory tumors, right? VIPoma, gastrinoma, all right, glucagonoma, insulinoma, all the places we can use this drugs called octreotide. Okay. Now we are coming into the drugs from the endocrine system, more or less, which have important side effects that you and I need to know. Hypoglycemia. Hypoglycemia is a lethal side effect because it could lead to coma. So make sure you know the drugs that can cause hypoglycemia, not just for exam, but for saving people's lives, right? So insulin can cause hypoglycemia, but in the insulin also, which insulin has highest risk? The answer is rapid acting insulins. Rapidly acting insulins, because they quickly get absorbed, and that can cause hypoglycemia. So who are these? Lispro, aspart, glulicine. These are the guys that are rapid. Amongst the drugs, we have sulfonylureas. Okay, sulfonylureas. So we should remember this. And there are some other drugs called meglitinides. These are drugs when you take, they make you release insulin. So again, insulin causes hypoglycemia. Best example, any drug starting with the name GL is a sulfonylurea. GL for glucose, glimepiride, right? Glyburide. Any example from GL, this is sulfonylurea. Okay. Now, since we said this, please remember in hypoglycemia, beta blockers should be avoided, right? Beta blockers should be avoided in the diabetic patients. Next, weight loss. If you talk about weight loss, there are drugs called GLP-1 agonists. All right, who are these GLP-1 agonists? Drugs like liraglutide, semaglutide. I told you about the brand called Ozempic, which is very famous these days. Yes or no? So you must know semaglutide, it is the oral drug. Liraglutide, it's an injection. These are drugs quite famous for the weight loss now. And if you're talking about a new drug that has been approved in diabetes, which is also used in weight loss, it is tirzepatide. Okay, tirzepatide. So it's a GLP-1 and GIP-1 drug. It works on two things. So it's there in our notes also, but just quickly revising, tirzepatide, it is the drug that is for the weight loss. Okay. Lactic acidosis, I already told you, this is by the drug called metformin. Flatulence and diarrhea, it is by alpha glucosidase inhibitors. Example, acarbose, voglibose. The name says it all, absorption of carbs, right? Absorption of carbs. UTI, genital infections, Fournier's gangrene, euglycemic DKA, all these things are caused by SGLT2 inhibitors. Okay. Rash, agranulocytosis. These are side effects from the thyroid topic by the drug of choice of hyperthyroidism called carbimazole or methimazole. Okay, carbimazole or methimazole. These are those drugs. All right, sir. Hepatotoxicity, it is by the drug called PTU, propylthiouracil. Propylthiouracil. This is the drug called hepatotoxic drug from this list. Esophagitis, osteonecrosis of jaw, it is seen by the drugs called bisphosphonates. Bisphosphonates, that is dronate drugs. Dronates are generally considered to be the drug of choice in the osteoporosis topic, right? Esophagitis, that's why we should ask the patient to drink more water and sit straight at least for 30 minutes after taking the drug, so that the drug passes away, more easily into the lower GIT. Okay, bullseye maculopathy also, it's an important side effect, although not from the endocrine chapter. There's a drug that is hydroxychloroquine, HCQ. This can do bullseye maculopathy. This is the drug we generally tend to use in rheumatoid arthritis. Okay. Next question. A patient was diagnosed with HIV. Further investigations revealed the patient also has TB. Treatment was initiated as per the protocol. Which of the following is the best prophylaxis for the peripheral neuropathy caused by the medication in this regimen? Okay. So, dear friends, what we must all know, the rule is when somebody is having TB HIV, first we will give the TB treatment followed by the HIV treatment. There should be at least a gap of 2 weeks in between. Otherwise, there is a risk of something called iris syndrome. Okay. Now, you can watch my other videos where I have explained these things to you. Anyway, my strong suggestion to all of you is, in this small period of time, we cannot cover everything as such. So, what we faculties generally do is, in each video, we tend to give you some topics which are new topics that you have to see by watching the different, videos. So, I think there are 3 to 4 videos of mine, 25 important question videos. Please do watch those videos along with the one you're watching right now, and definitely at least 8 to 12 questions you can expect from this in your exam. Okay, I'm not saying ditto copy pasted questions, but the concept, the themes of the questions will be there, and the history is the proof. You can go check even the exam papers, the questions that has come. A lot of questions have come straight away from this 25 question series right here. So make sure, in pharmacology, you're watching the previous ones as well. Okay. So ATT, ART, now that we got that. Anyway, some of you will ask me, sir, we have to study and do so many things. Sure, I understand that. See, when should you watch this videos? What I'm talking right now is in the last week before exams, especially in the last 1-2 days, preferably on the last day when you're so tensed, you're not able to study on your own. Just put these videos of mine and play them. Last minute you will get some passive information going in your head, even though you're in anxiety. That time, one day before, if you have heard these things, some things will come out for sure in your exam. You will be able to reproduce them. Okay, I know pharmacology is overwhelming for a lot of us. Sir, so many things to remember, how to do that. I understand that, but unfortunately examiner is not going to listen to that and give you any less question. Jitne aane hain, utne aayenge. Questions will come. You have to go according to the exam. That's why watch this at 2x speed in the last day. This is my advice. Now you do whatever, you divide this and watch one video every day, little by little. See, this will definitely help you in exam. And as you know, pharmacology is not just about drugs. It opens up your concepts about a lot of things, right? So many questions we did so far. You're able to get the diagnosis, internal medicine diagnosis. So things like that, your mind will start opening up. So make sure you do this. All right. So anyway, coming back to this topic now, as I was telling you, first we give TB treatment, anti-tubercular treatment, followed by HIV treatment. Otherwise, there is a risk of iris. Now, when you give TB treatment, there is a risk of peripheral neuropathy. There are 4 drugs we give in ATT, right? H, R, Z, E. From this, the drug called H, that is isoniazid, it decreases vitamin B6, that is pyridoxine. And pyridoxine deficiency can cause neuropathy. So that's why we should supplement pyridoxine whenever we are giving TB treatment, so that neuropathy can be avoided. Okay, I hope everybody understood. TB drug side effects अच्छे से पढ़ना. Make sure you're revising that well, okay? What is the mechanism of action of the drug B in the B-PALM regimen? So, according to the new update, I hope everybody knows that now something called MDR-TB in India will be treated by this short course therapy of 6 months, that is B-PALM regimen. Earlier, the treatment of MDR-TB was longer, much longer. Now it is 6 months. By this new treatment that is claiming that it can treat this in 6 months. What is B-PALM? B for a drug called bedaquiline. Bedaquiline, this is the drug that inhibits ATP synthase. They're asking that only na, ATP synthase inhibitor. So this is the answer, ATP synthase inhibitor. Okay. So when you're going to bed, you need energy. ATP is needed when you're going to bed. Okay. Next, B-PALM. P for Pritomanid. Pritomanid, this is a drug that is a mycolic acid inhibitor. Okay. L for linezolid. Linezolid, it is a protein synthesis inhibitor which works on 50S ribosome. And then M for moxiflox, that is fluoxetine drugs. You should know fluoxetine drugs work on this enzyme called DNA topoisomerase, also called as DNA guidase. Sirji, answer is option C, but I was discussing the other options also in this. Okay. Next, certain side effects from the topic of, antibiotics. Redman syndrome, it is due to histamine release. Histamine causes this vasodilation, which is presenting as a red thing, Redman syndrome. It is a drug called vancomycin. Vancomycin, the drug that we use in the cases of MRSA. MRSA drug of choice is vancomycin. Gray baby syndrome and bone marrow suppression, it is by chloramphenicol. Chloramphenicol, it causes gray baby syndrome. Disulfiram-like reaction, it is by the drugs called cephalosporins. Teeth damage and bone damage. Teeth damage and bone damage, you must know this is by certain drugs called tetracyclines. Tetracyclines, teeth and bone damage. Tendon damage, cartilage damage, it is by fluoroquinolones called fluoxetine drugs. Fluoxetine abhi padhe the. Ciproflox, Norflox, Oflox, Moxiflox, Gatiflox, these drugs. Okay. Serotonin syndrome, bone marrow suppression is by linezolid. Carnecterus and SLE, it is by sulfonamides. Nephro and ototoxic is aminoglycosides. Nephro-ototoxic na, gentamicin, amikacin, streptomycin, etc. These are the drugs that come in this class. Okay. Next, certain side effects from anti-cancer drugs. Okay. Hemorrhagic cystitis, NSAIDH, etc. It is caused by a drug called cyclophosphamide. Cyclophosphamide. And the antidote for this, it is called as Mesna. The full form of which is given here. This is known as Mesna. Okay. Pulmonary fibrosis, it is seen by the drug like busulfan, bleomycin. Okay. That is about this. Flagellated dermatitis, it's a rash that looks like tiger print. This is also seen by bleomycin. Dilated cardiomyopathy, dilated cardiomyopathy is doxo and donorubicin. Doxo and donorubicin drugs. anthracycline class of drugs in anti-cancer. One of the most emetogenic drug, that means the one that causes that vomitings, etc. Nephro and ototoxic drug, it is cisplatin, platin class of drugs. There is one antidote called amifostin that you must remember in this topic, that is cisplatin. Megaloblastic anemia due to bone marrow suppression, it is methotrexate. Why? Because methotrexate, the mechanism of action is it blocks dihydrofolate reductase. That means it blocks folate. Because it blocks folate, it is causing megaloblastic anemia. Because it's blocking folate, in toxicity, folate levels are very less. How do you think you should treat? Give folate from outside. So the antidote of methotrexate is folate. Okay. Hand-foot syndrome. 5FU. I said when you say FU to somebody, you show your hand. So hand-foot syndrome, it is this drug. Okay. Capecitabine. So bone marrow suppression, one more drug, vinblastine. Okay, vinblastine, it blasts your bone marrow. Vinblastine, it blasts your bone marrow. All right. Last few questions. Which is not the mechanism of action of theophylline amongst the following? Now you must know theophylline is a drug that we can use in asthma, COPD like diseases. It's a bronchodilator type of a drug. Theophylline, the word itself, we can use to remember certain things from this. T, theophylline, this drug, HE. The H here stands for, it inhibits one enzyme called histone deacetylase, which gives anti-inflammatory action to this drug. So that means it is a mechanism of this drug. Okay. Next, T, I would want you to pronounce like theophylline. So it inhibits 3, something 3, that is, PDE3. PDE3. So this is one enzyme that is inhibited by this guy. Okay. Theophylline. So it's going to inhibit certain enzymes, right? One is histone deacetylase. Next is theophylline, that is PDE3 inhibitor. And one more enzyme is there, that is, it will be working on adenosine receptor also. So what all is it working on is PDE3, histone deacetylase and adenosine also, adenosine receptor drug. Okay. So now that we said that ये 3 तो mechanism है, which is not a mechanism in this, the answer is this one. It is actually seen by the GREL drugs, which are anticoagulant drugs. Now ADP inhibitors are GREL drugs. Okay, clopidogrel works by this mechanism. Okay. Now, since we have said that, let us go to the next thing. This is the graph from which certain questions, what are the things that we are supposed to remember. Highest efficacy and highest potency drugs from the following DRC, dose response curve. Okay. Efficacy, whenever they ask, look for the height. The more the taller the height, the more effective the drug. That means from the given list, the tallest drug is B. So that means the most efficacy drug is drug B. Potency is related to dose, the one which requires less dose. So guys, remember in this graph, left side will be high potency drugs because they require very less dose. Right side, they will be low potency drugs because they require more dose. So according to this rule, drug A requires the least dose. That's why it is the high potency drug. So high potency is drug A, high efficacy is. So that means B and A should be the correct answer. Drug B is the highest efficacy. Question asks that. Next they ask high potency drug. Drug A is the high potency, so B and A. That should be the correct answer here. Okay. Now, these are certain graphs that you must keep in mind for this concept, what we call as competitive inhibition and non-competitive inhibition. Competitive versus non-competitive inhibition. Okay. Now you must know, in competitive inhibition, imagine a drug was producing effect at 5 mg. But now in the presence of a competitive antagonist, what will happen here is you need to give more dose to achieve the same effect. Okay. That means there will be shift from left to right. Are you understanding? There will be a shift from left towards the right. So what is happening? Earlier I was giving less dose, I was achieving what I wanted, but now to achieve the same effect, what do I need to do? Give more dose. That means the dose to be given increases. What is dose also called as? Km increases, Vmax stays the same. Vmax stays the same. All right. Vmax means effect. Effect same here, na? Effect is staying the same over here. But what is happening? The Vmax, the dose is increasing. So you can see the picture. Finally, effect to utna hi hai, Vmax stays the same, but then dose requirement has increased. So we learn in competition, you need to run more kilometers to win. Think of it like that. In competition, competitive inhibition, you need to run more kilometers to win. Okay, I hope you all got that. Next, this graph below is called Lineweaver-Burke plot. Okay, in the Lineweaver-Burke plot, just remember the mnemonic. If you see the lines crossing, if you see the lines cross, it is competitive inhibition. You will see this in biochemistry also, by the way, like the same graphs, etc. Now, if you talk about non-competitive inhibition, what will happen? Imagine a drug was producing more effect before, but now in the presence of a non-competitive antagonist, the effect will decrease. The slope will flatten out. That means in this non-competitive inhibition, Vmax decreases and Km remains the same. It's opposite. So how to recall this in the exam quickly? As I said, you should remember, in competition, we need to run more kilometer to win. Okay, that's what we need to do. Non-competitive inhibition, as you saw here, this is the story. Okay, lines do not cross in this. And finally, now you see here toxicity and the antidote. We already learned OPs and carbamate toxicity. The antidote is atropine. Okay, atropine. Belladonna, atropine and Datura, we are going to give physostigmine as we discussed before. Okay. Beta blocker toxicity, we give glucagon. Beta blockers decrease something called cyclic AMP, whereas glucagon will increase it back. That's why we give it as an antidote. Digoxin, we give a drug called Digibind. It's a monoclonal, it's an antibody. Okay, it's a antibody. It binds to digoxin, Digibind. Paracetamol, N-acetylcysteine. You all should know paracetamol increases one bad guy called NAPQI, and NAC will reduce that NAPQI. That's why it's an antidote. Okay. Aspirin barbiturates don't have an antidote, so we remove them by that universal antidote called force alkaline diuresis. If the drug is acid, called 8, folate, glutamate, they are all acids. Acids are removed by alkaline diuresis, and vice versa. Alkalis are removed by acidic diuresis. Benzodiazepine, flumazenil, Benz में full मजे. Okay, Mercedes Benz second mnemonic, Benz में full मजे. Opioid, I already told you, naloxone. Alcohol, flumazenil. Okay, alcohol, flumazenil is the antidote. Curare drugs, neostigmine is the antidote. neostigmine is the antidote. And for two drugs, that is rocuronium and vecuronium, new antidote called sugammadex. Okay, sugammadex. This is the new antidote for the drugs like rocuronium and vecuronium. All right, so that's it about this session. Hopefully this helps you in the exam. The whole idea of doing this is to make you revise the highest yield topics. Okay, again reminding you that you must go over the previous videos of mine also. That will definitely help you, my friends. Divide the time accordingly in the next days, whatever the time is left for the exam. Do this 4 or 5 videos, and definitely decent amount of questions will show up in your real exam. And these are the groups you can follow me right now. Even on the Telegram, I'm posting certain questions once a week, so you will have like bulk questions coming up, and that's where you can again revisit the facts that you know in your head and consolidate them. So thank you very much. Wishing you all the very best for the upcoming exam. Again, I will be waiting for your results to come. Please do text that yes, you have seen this session and the previous other sessions as well, and this helped you in the exam, so that I get to know like what we are doing, because your response tells us that okay, this type of things are coming in your exam, and this is how we should also understand the important questions. Okay, and do comment, because this gives us energy and the boost to do more sessions like this, to do the best for all of you. Okay, so give us like and thumbs up and the comments. So thank you very much, everybody. Take care. God bless you all.